here, there is a sort of a tent. There is a complete separation of the capsule from the cortex. It has a beautiful advantage. You can go here through this tent and perform hydrodissection. In this case, the irrigation aspiration is going to be very easy, and it's going to take just few seconds. And you just go in and never out until you finish irrigation aspiration. And look here, after irrigation aspiration, the zonules are still intact, indicating what? Indicating that there was no movement during irrigation aspiration, and vitreous didn't prolapse during irrigation aspiration, which lowered the incidence of retinal detachment in the future. And you can easily go in and eat the capsular bag with a cutter, and here at conclusion of surgery. Here and I, even without zonular attachment, there is only here zonular attachment peripherally. And there is a long-standing, can you see here, from 3 to 6 o'clock position, there is peripheral anterior synechia. In these cases, how can you go for anterior rexus? With a microrexus forceps, you push in a direction parallel to the subluxation. Push, 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 and then you complete in the conventional way. With a Y-shaped cannula here, you push the rexus towards the hook to facilitate hooking of the anterior rexus and then complete the surgery. This is the beautiful tent where you can go for hydrodissection, and then once in for irrigation aspiration here, after irrigation aspiration, despite you have an area of zonular dehiscence, there is no vitreous prolapse. And then you complete the surgery in the usual way. If the subluxation is downward, you use a Sinskey hook or a dialer to pull the rexus to facilitate the hooking and centralization of the lens. And if the subluxation is upward of the lens, you use a Y-shaped spatula like this one, and you push the rexus towards the hook to facilitate hooking, and then continue the surgery, irrigation aspiration, and here at conclusion of surgery. One more step, one more thing about the surgery. Even if you have a large microspherophakia like that, even if you have these beautiful zonules, don't ever leave to think to leave the capsular bag. You have, after finishing irrigation aspiration, this is beautiful bag. Don't leave it. You have to eat it up, all of it with a cutter, and leave the eye aphakic like that without capsular support. Why? Because if there is a large microspherophakia, can you see this is the edge? And if you think to leave a beautiful anterior and posterior rexus here at conclusion of surgery, can you see this is the edge of the lens? What's going to happen? Few months after surgery, complete fibrosis of the capsular bag, shrinkage of the capsular bag, and here elongation of the zonules. Why? Because the capsular bag, the zonules couldn't withstand the normal fibrosis of the capsular bag. They are originally diseased. Unlike the congenital cataract, here just few months or years after surgery, you have a beautiful capsular support. This is another eye. Can you see this is a microspherophakia? Here we left a beautiful anterior and posterior rexus here at conclusion of surgery. Few months after surgery, extensive fibrosis here and zonular elongation obstructing the visual axis that we had to go again with a vitrectomy to clear the visual axis. And here at conclusion of surgery. After surgery, immediately we have a deep anterior chamber, and we fit the babies with aphakic spectacles. And in cases of older children, as in this case, having a dislocated anterior microspherophakia and a subluxated one, we can implant iris glow lens as a secondary procedure. This is a case with a long-standing here and here at conclusion of surgery. Here immediately after surgery, before and few months after surgery, the left eye, the pressure was controlled and we were able to save the right eye. And of course, by examining routine exam of her brother, we found that he has the same condition here immediately after surgery, wearing the aphakic spectacles And 1 year after surgery, he was glaucoma-free. So finally, to conclude, microspherophakia may present with high myopia, with a high astigmatism that is not amenable to be corrected by spectacles, and it is embryogenic. It may present with anterior or posterior dislocation of the lens, or may present with all varieties of pediatric glaucoma, congenital or acquired, primary or secondary. That's why it is considered as one of the pediatric ocular emergencies that had to be dealt immediately with bilateral lensectomy. And thank you very much for your kind attention.
Thank you, Dr. Nihal, as usual, from Alexandria University. I am from Alexandria, so excellent talk. I think we have a lot of questions, maybe from Aik Ahmed, from Dr. Khan, but time going on. So I have to shift for Dr. Ammar Safa. Hello, Dr. Ammar, Dr. Prasen, if you want anything, you are one of us moderators. So Dr. Ammar will talk about 3D head-up surgery in ophthalmology.
Hello, everyone. Thank you so much for the invitation. I'm just sharing my screen here in just a second. Can you see it? Okay. All right. I can see that you can see my screen, so I'm going to go ahead. So I have no right now. Feedback from somebody. Can you please your phones? Okay. So our specialty is a very non-tactile specialty, if you will. So unfortunately, we are not like internists who can actually, palpate something or put their finger or their hand on the patient and be able to identify a problem. We depend so much on actually visualization of the internal parts of the eye, and for that, over the several decades in the past, there's been major improvements, starting with very simple things, and we made our way into technology, improving our ability to visualize things, and actually creating systems that allow us to be able to see the structures inside of the eye in order to be able to do surgery, including the primary or initial microscopes that were initially created. But even with the most advanced microscopes, you always have the issue of the surgeon having to kind of like position the head and bend the neck like this, as you can see here, in order to see what they're doing. Even with the most up-to-date systems that we have right now in the market. So basically, what happened then with the technology improvement, with the fact that now we have a digital revolution, if you will. In 2008, Truvision Systems introduced what they called a three-dimensional heads-up ophthalmic surgical visualization system, which basically consisted of a high-definition display, a monitor, a camera that's also high definition connected to that monitor, and a passive 3D glasses. I'm sorry, just a second. I'm not able to control this very well. All right. Sony in 2012-2013 entered the market with their own heads-up system. It was mainly designed for neurosurgery, but they came up with an ophthalmology module. And this module, as you can see in the picture here, came with a headset. It wasn't glasses, it was just a headset, as you can see. But unfortunately, the uptake wasn't really very good in the ophthalmic community for this system. Alcon acquired Truvision in 2016 and created the system that we currently call Ingenuity, which is a visualization platform, which is specifically created and designed for ophthalmology, for mainly vitreoretinal surgery, but then also they branched out into anterior segment, as we will have a talk about that later on today. So the system, again, the idea is the same. You have three components trying to come up with an image that feeds into the surgeon who is wearing the 3D glasses. It is basically a monitor that's large and very high definition, 4,000 pixel monitor. And you have a 4,000 pixel camera that improves the overall resolution and visualization. So here's basically the camera. It's an HDR camera that acquires this high resolution image. The good thing is it passes initially through a processor that basically elevates the intensity of the image, which I'll show you some examples, and allows for using a much dimmer amount of light in order for us to see what we need to see in order to operate and do our surgery. And obviously the physician now has a 3D glasses that are comfortable that allow you to see 3D and 2D. So the idea is to take this image on your left that is good, high quality, but intensify it and improve the resolution, the vividness of the colors, and allow you to see a lot more detail. So if you look at this very pretty lady, you can actually see all the details in her mouth and her eyes, but you really can't see much details in the background where the mountain and the greenery and the water. So what the system does is it improves the depth of field and make you see much better detail in all different layers. So the visualization becomes very important, especially with VR surgery, where you need to be focusing on one area while you're working, but at the same time being able to see the entire picture. The other advantage of this system is when you're working on the macula and trying to do some really fine work, you actually can have the macular hole, for example, as you can see on your right with the digital system. The whole monitor shows you this one area that you have very high detail, while the left side it shows you the normal image that you would see in a normal microscope. Zeiss also introduced a couple of years ago the Artivo system, which is their own system like the Ingenuity. It uses the same pretty much idea. It offers a little bit more compactability because it is integrated within their own system, but unfortunately at the same time does not allow you to use any other microscope. So that is a little bit of a limitation, but it basically has the same idea. It's a very high resolution camera, and it promises a high resolution image with outstanding depth of field and a dramatically reduced requirement for light intensity, gives you natural color, and also it has the ability for cloud connectivity for your backing up your surgery and saving them. So the real question is basically, does, from a clinical standpoint, does the 3D system, or the heads-up surgeries as we call it, the vitreoretinal surgery, does it result in better visual outcomes? So is the patient seeing better, getting better outcomes from these surgeries versus the optical systems? And will there be any fewer or lower complication rates? Will the surgery be more efficient, maybe reducing operating time, maybe reducing the turnover time? And obviously for us as surgeons, will it be ergonomically better, more comfortable, and hopefully we can retire more comfortably? So multiple retrospective and prospective studies have been done to look into these questions. And basically all of them concluded that basically you have a similar outcome from a success standpoint, from a visual standpoint. It's similar but not better than the optical system in performing at least complex vitreoretinal surgeries. There is no increased rate of complications, but no decreased rate of complication at the same time. There's no conclusive data of any increased efficiency. And if you ask me, at least in the first month or two, the efficiency decreases, not increases, because of the bulkiness of the equipment and the ability to move it in and out. And most studies report subjective preference, let's say, from the staff and from the surgeons who are using the heads up. So let me now just spend the rest of my time telling you about my personal experience with the digital systems. So the issue of seeing multiple levels, I think, is very important. As you can see here, I'm shaving the anterior vitreous with this retinal detachment. And this is a great case to illustrate that, because you have 3 layers. You can see where I'm shaving, you can see the detached retina, and you also can see the posterior pole and the optic nerve quite well in this video. Also, it illustrates very well how you can see all these layers. So this, I think, is in my opinion, an advantage that I noticed when I use this system. Here, I'm trying to remove the subretinal fluid in this detachment case, and you can see how beautifully you can see the fluid getting out of the hole. You can again see the retina where you're working and the posterior pole in a very, very good resolution. This is a case where you can see the PVD coming up really nicely there. This is a patient who had a pre-retinal or sub-ILM actually membrane. You can see that the PVD comes up, but the blood continues to be contained because it's underneath the ILM. And you can really see the differences between these layers. And after you create a hole in the ILM, you actually can can evacuate this blood. But the reason why I wanted to show you this video is this different in colors. You can see the brightness here in the red. This system allows for changing the filters or the channels, is the way they call the color channel, that gives you intensification of the colors where you can see blood a bit better. And this is where you can see these differences going back and forth from one to the other. This can be, that can prove to be helpful in certain circumstances. So after you clean, this also allows you to do a very careful, after you evacuate that blood, gives you a very good view and very good detailed view in order to be able to evacuate and basically vacuum out the blood and make sure that you evacuate everything. And this is the edge of the ILM, as you can see here in this case. The ability to see, if you have an OCT, intraoperative OCT, and be able to actually magnify it and see it on a big screen TV, as opposed to looking through the oculars, I believe is a major advantage. You can move the scan and actually locate it in any place you want. I believe this is one big advantage, in my opinion, as rather looking at it in one of your oculars. So the advantages, if I want to summarize them, when you're looking or you're basically trying to focus on a much bigger 60 or even more inch high definition monitor, this gives you a much larger operating field of view and it enhances the depth of field. This is very important in my opinion. It gives you a superior view when you're doing macular work. You're seeing very, very small details in what you're doing. And of course, like we just discussed and showed you on the video, they have a better intraoperative OCT imaging. The ability to reduce illumination, in my opinion, is a major, major plus because you use pretty much 5% only intensification of the light, which can be processed and you get a much better illumination. And that, of course, reduces the risk of toxicity to the retina. And of course, it's always good to have the engagement of your scrub nurse, seeing exactly what you're doing, as opposed to looking at the oculars or looking at a small monitor next to you. The disadvantage is that so far we still have a need for this guy who will be basically a dedicated person to control the functions, especially if you need to do any changes in the colors. This will potentially be solved soon where you, with your foot pedal, can actually get everything taken care of. And of course, there is still that little bit of a lag, very, very small, and it's been much, much improved than the previous versions. But I feel that there still is a very small lag, which you can easily overcome after you do a couple of cases. The display of parameters here has always been hyped up as a very important feature, which I believe is useful. But in all honesty, for me, I don't really look at it that much. I still like to hear it because I like to focus on what I'm doing in the retina and really not look at where is my vacuum or where is the cut rate. I still like to have the engagement of the staff telling me these things. And like I showed you earlier, the color filters sometimes can actually offer some advantage as to visualizing the vitreous better or areas that have bleeding. So if the question is, are we there for prime time? Is it ready for the heads-up system to be actually in every operating theater? Probably yes, I would say almost there, but I'm getting a lot more positive with this system than the optical. But definitely for the budding vitreoretinal surgeons that will probably become the stars of vitreoretinal surgery in the coming 15, 20 years, they're always sitting down playing video games, as you can see. And I think for them, it will be definitely the system of choice compared to anything optical. They might actually look at us and feel that we are really obsolete. And how did we ever do surgery looking through a microscope? Thank you so much for your attention.
Thank you, Dr. Ammar. I think I asked Dr. Passan because he's a vitreoretinal between us. So if you want to ask you any question, we have 1 minute. Dr. Passan.
Excellent. Can you hear me?
Yes.
Yes. We can hear you.
Excellent talk, Dr. Ammar. My only issue is when I used Ingenuity, I found difficulty in visualizing the inferior and the superior retina. Because if you look at your images, you're able to see the nasal and the peripheral retina very well, but the inferior and the superior, especially when you're going to the peripheral part of the retina, is a little difficult. Did you experience the same thing when you were operating on the detachments, if you had to do a vitreous-based shaving? Or do you find the same issues?
No, actually, I have not. I will pay attention again because I'm actually going to use it again in the coming month, but I really do not recall specifically not being able to visualize a part of the retina. So I'm not quite sure. Maybe the tilting of the microscope when you used it may have been an issue.
One of the issues was the camera is a rectangular shaped camera.
Mm-hmm.
So what it does is, if you look at your images on the screen, you'll always see the nasal and peripheral as circular, and the superior and inferior are flat. So when you go to the periphery, when you're doing under, say, you're using your microscope, you can actually tilt your eye and you can see it better. But on the Ingenuity, if you're going on high magnification, the inferior and the superior periphery become a little difficult. So that was my experience. I think maybe in the next generation of machines, they'll probably have better cameras to help us out. But however, excellent talk, and I think that's our future.
Look, I've started using this system back in 2015, and the change I've noticed over the years have been dramatic, really.
Yes.
From 2016, probably around 2016 until now, the first generation until the recent generation, I think has been a huge leap forward. And like everything digital, I think there will be further advancement. I mean,
yes, true.
Thank you, Dr. Passan. Thank you, Dr. Ammar. My colleague and my friend beside me, he will talk about Dr. Hayat Khan, about ROP, about the visual rehabilitation after management of ROP from the medical and the surgical point of view. Please, Dr. Hayat.
Thank you once again, QIC organization, for letting us present this wonderful meeting, and thank you all the audiences for being there. I see Dr. Aik Ahmed sending nice messages, and I'll start with this interesting topic about ROP with this case. So it's a very usual case that comes in with our retinal colleagues with a 25-week or a premature baby landing up with ROP zone 1, stage 2 with the plus disease. And what happens? We would like to go in and we would like to bilaterally send in the patient for OR, and then we injected Lucentis at 35 weeks, which responded quite well. The same patient on the follow-ups developed recurrence only in one eye, that is the left eye. And with this recurrence, they had to laser, and once it was lasered, the patient on their follow-ups was reasonably doing very well. And then suddenly COVID-19 comes in, and that's a very real thing now we are dealing with, how patients are lost sometimes. And the patient then lands up after 7 months, and when we do a cyclorefraction, as you can see there, there is a huge anisometropia. The left eye has a huge myopia. If you see, the spherical equivalent is huge. And that further has caused left eye amblyopia and then an esotropia of that eye. So does it surprise us? What do we do about this? And I think that's what we're going to discuss in today's presentation. So premature patients with ROP, they have a greater chance of all these clinical scenarios. Not only, it may be causing very simple refractive errors, but definitely they have a very major role in the long term for successful treatment. Anisometropic amblyopia, strabismus, cataract, glaucoma, late onset retinal detachment, vitreous, hemorrhages, and so on. So I would put it as simple as what you see here in this picture. This is a relay run in which there are 2 people in the same team. It would be even better if this is not a relay, if a single person is handling. But what happens when you have team and we want to have this race to achieve best visual outcome for the child, it has to be coordinated. And it's especially important when you have different teams working out. You have a retina team, and then you have a pediatric ophthalmology team, and sometimes the patients are not handed over properly. Sometimes they lose their follow-ups because of parents issues, sometimes because of now recently the COVID issue, and that actually is the challenge that we have to see. So good referral system, a robust system of follow-up in which pediatric ophthalmologists get a chance to take over as a good team, and then finally get the best results. So globally, what we are doing about this, especially when we look at laser, which is still the hallmark of the treatment, despite all the advancement in the screening and management, we still have ROP as a leading cause of blindness and visual impairment worldwide. Now, this reduces the morbidity, but in terms of the structural outcome, but still there is limited functional outcome, which is still a long way to be achieved. Now that we include myopia, and when we see high incidence of a myopia in these cases, the prevalence can be as from 0 to 16% as documented. And way back in the ETROP study, myopia prevalence was about 58% in severe ROP cases, but when they received a laser photocoagulation, the number went 70%. Now, severe lasered ROP patients, they have a rapid progression of myopia, so they have to be regularly followed, and that's where the role of whosoever is the pediatric ophthalmologist comes in. So what are the mechanisms? Of course, sometimes we feel that it is the arrested anterior segment growth or disturbed retinal signaling. And what are the different parameters which are affected are increased lens thickness, steep corneal curvature, anterior chamber shallowing, and axial lengthening, which all are hindrance to the emmetropization of the eye. And I think that is the key reason why myopia is so much a problem in these children. Now, high myopia, of course, are related to the zone 1 patients who have received laser. They are more prone as compared to the ones who got the injections. Now, there are several documentation, as you can see, different reports, and they even found that the zone 1 disease itself is an independent risk factor. So not necessarily injection or laser has, so it is quite we really don't know the exact, it needs a huge amount of data collection and regression studies to finalize where we are on this in terms of the magnitude and the occurrence, and accordingly we have to plan our strategy. So Kumar et al., they reported this in 2019 that high axial length is the cause of myopia and it's not the lenticular thickness, while earlier reports, they show that higher lenticular thickness is also a contributing factor. So there is still actually a controversy in knowing the exact mechanism, and definitely we need to have more studies to come up with a final answer to know exactly what's going on in these severe ROP cases and how do we have to go about and how we change our protocols. In terms of astigmatism and strabismus, if you see there again, you will see that they have a high prevalence of astigmatism with the laser patient of ROP. And these eye have, the lasered eye have high astigmatism, and strabismus is also present in these cases. Now, 1 out of 3 cases do land up with strabismus, and that is due to amblyopia and the associated refractive errors which do come in, especially if it is unequal amount causing an isometropia. So prematurity itself is an independent risk factor for strabismus cases. So again, we have to come up with further studies to know. Cataract, again, there is a big study which has been published 2017, which talks about a large cohort out of which 28 eyes of 22 patients were studied, and 11 out of these 28 eyes had vision, which was, that's about 40%, had 2200 vision. So there are cases which need attention, and these patients, once they develop myopic shift, whether they are left pseudophakic or aphakic, and the patients who are aphakic, they come up with a higher amount of myopia. So early identification, regular assessment, and prompt intervention is the key, and it's always a mixture of refractive errors, amblyopia, and strabismus which go along. So screening programs have to be created, awareness have to be created, and of course, the long-term prospective control studies have to be taken up to understand the mechanism of myopia and the development and its progression. Now, sensory outcomes have also been important aspect that we have to look in, especially the fine stereopsis, the gross stereopsis. There are not much of a substantial literature which document these and to validate as where we are in terms of these patients. But definitely in future, we would like to have more papers coming up which elaborate on this. So premature babies, they may have delayed visual maturation. They may have inability to see and recognition at the level of brain. And of course, optic atrophy, blindness due to cerebral palsy and other comorbidities. So therefore, they need a lifelong periodic eye examination. So I'm quickly going to go on to this important paper published this year by Yen and Chen, in which they have actually looked in very carefully into the structural, the structure as well as the different parameters of refraction, the optical biometry in children with ROP and who had gone through the anti-VEGF injections or laser. And there are 47 eyes of 25 children which were studied. And what they found something really interesting, especially when they looked into the ROP patients, comparing both of them. So if you see on the right side, you have the lasered eyes, the retina, and on the left side, you have the patients with injections. And what we see on the OCT angiography is that the superficial capillary plexus in the lasered eye, they are comparatively, if you see there, they have smaller amount as compared to the ones which are from the injection. So the FSZ is actually smaller. And if you see the vessel density, the laser group has significantly high at the fovea, but it is lower at the parafovea as compared to the injection group. In terms of the spectral domain or OCT that you see below, you see the thicker central foveal thickness with a prominent inner retina in laser group. And these all show that right at the very structural level, there are differences, and that is causing functional changes. And then going into the different biometric parameters, if you see there, again, you come up that the average keratometry, there it is higher in laser group, the anterior chamber depth is shallower, the axial length is definitely higher, and of course, also the lens thickness is thicker. So finally, this concluded that we need to do further studies and have a further ground on how these ROP cases have to be dealt. Now, this is again, and there are a lot of papers on this and a lot of publications regarding myopia and their association with this disease. And of course, last but not the least, we have to talk about the BEAT ROP study group, in which the refraction was available for 109 patients. And what they found was that high myopia was more prevalent in cases of laser as compared to injection in zone 1 as well as in the zone 2 disease. And the anterior segment development was different in both these groups. So I'm not going much into the details, but what I would say, it's a cricket season. So I always say that it's not over till the last ball. And the take-home message is the lack of screening and treatment can render a baby blind. And it is all and none phenomena that's unlike any other disease. And vision training is an essential part of a good ROP management. And thank you so much.
Thank you, Dr. Khan. I think we will have a lot of questions in this because you give Lucentis. We have a lot of preterm baby we are examining a lot in our hospital. From our experience, we give Avastin giving better result with us than Lucentis. Maybe after that we can talk about that, if there is difference in this, or to be repeated or no. Also, we can talk about that, but not now. I think if we have time, we'll go for all these questions. I think we have to move for Dr. Hassan Khalid. Dr. Hassan, how are you?
I'm good,
we'll
thank
go
you.
Again for 3D head-up surgery, but in cataract now, not vitreoretinal.
Yeah, yes.
We are going.
Okay, thank you. Do you hear me? Firstly, I would like to thank Dr. Muhammad Al-Amri for his kind invitation for this big conference. Here I'm going to talk about the 3D heads-up in cataract surgery, mainly in phacoemulsification. In traditional surgery, microsurgery using the binocular microscope can lead to deleterious neck and back posture that cause musculoskeletal fatigue and injury, which has been associated with reduced surgical longevity. And it's found that the prevalence of neck, upper body, or lower back symptoms among ophthalmologists has been reported in up to 62%. In heads-up surgery, in cataract surgery, this term describes the using the microsurgical procedure not by looking at the eyepieces of the microscope, but by viewing the microscopic image on the pinal display sent front of the surgeon, sent from a 3D camera set in front of the surgeon. This heads-up display system allows visualization in heads-up position, as it's clear in this picture. And this position eliminates the constraints imposed by the standard binocular microscope and minimizes the fatigue by providing greater degree of freedom to operate in more natural physiologic position without affecting the image quality or technical difficulty. There are two types, and there are also two principles for this 3D visual systems, classified as either passive systems or active systems. I will talk mainly about the passive systems. The 3D image is acquired by mixing two images horizontally and then passively separated them into polarized 3D glasses. This is the principle used in current heads-up display, like in Unity visual system. In active system, the 3D image is obtained by showing high-speed consecutive images from for the right and left eye alternately, while a special pair of electronic glasses actually suppress the image in the other eye, and this is the principle used in the most head-mounted systems. Here I'm going to talk mainly about the Truvision 3D and in Unity, and there are many types of the head-mounted 3D visual system. The Truvision 3D system in cataract surgery was firstly reported by the Vince talk in 2010 in the ASCRS meeting in Boston, who presented a retrospective analysis comparing the cataract surgery using a standard binocular microscope with a microscopic equipped with a Truvision 3D system. And Benstech reported an excellent outcomes in both groups with minimal procedure time difference between the two groups. And the interesting thing he notes that the rate of unplanned vitrectomy was 3 times higher in the standard microscope compared with the Truvision group. Here is the Truvision 3D surgical system, which is consists of a camera unit that attaches to a standard surgical microscope, sending stereoscopic images and video to a 3D high definition large screen monitor set in about few feet from the surgeon, providing a good visualization in real time. And this machine was approved by the United States FDA and has granted clearance for refractive cataract toolset and application that provide 3D graphical overlays for image guided cataract surgery. Another recently, Truvision has developed that TrueGuide and TruePlan applications, which have been designed for intelligent surgical planning to aid in achieving target refractive outcomes, including the use of the toric IOL implantation for the cataract surgery. And in one study, Solomon reported the result of toric IOL implantation using TrueGuide. He found that the eye, about 83% of eyes were corrected with less than 0.5 diopter of astigmatism, and 100 patients were corrected with less than 1 diopter of astigmatism. And the best corrected vision, it was 20/20 in 80% and better than 20/25 in 100% of the patient. Here is the components of the Ingenuity 3D visualization system, which produced by the Allergan, which consists of a 3D 4K flat panel display screen and 3D high dynamic range camera connected to the surgical microscope, with a 3D image processing computer and the console to store the 3D glasses and the cables and other accessories. There are many published papers comparing between the rate of complication and the duration of the time using the 3D visual system. In this retrospective big study, which all the surgery performed by one surgeon, there are 2,320 eyes involved in this study in 2 groups, 1,673 in 3D visual system who had cataract surgery with using the 3D visual system, and 647 using the traditional surgical microscope. In this study, they evaluate the posterior capsular rupture and vitreous loss along with that duration time for the cataract surgery. And it found that there were no statistical significant difference in both complication rate and duration time of the cataract surgery. And it was similar efficacy and safety for the traditional surgical microscope. Another published paper, which is a prospective randomized study comparing also the 3D visual system and traditional surgical microscope in 20 eyes. They evaluate the surgical time, and here also the best corrected visual acuity and the corneal endothelial cell density. They found that the best corrected visual acuity was significantly improved in both groups, and there were no difference in surgical time and also in the corneal endothelial cell density in both groups. And they concluded that the 3D visual systems are suitable and safer for the phaco-IOL surgery. Here also using the 3D visual system using low light intensity condition in different type of ocular surgery, not only for the cataract. There were 72 eyes involved in the surgery, 60 eyes for cataract surgery alone, and 7 eyes combined cataract surgery with glaucoma micro device implant surgery, 5 eyes combined cataract with vitrectomy surgery, and 2 eyes with only vitrectomy using the dimer illumination set through the microscope. And it's found that all the surgery were completed without any complications under the low illumination condition. Back to my experience in this field, actually, I have tried the Ingenuity 3D visual system in April 2018. I have operated the 10 cases only, phacoemulsification with IOL implantation. It was a unique experience for the first time. I don't find any difficulty in dealing with the 3D depth of both cataract and anterior chamber. And I found also a good handling with the instruments inside the eye. Here, I'm implanting the IOL using the 3D Ingenuity visual system. I found also that performing all steps with heads up, which really makes your back and your neck much better than traditional way, as no more upper neck pain and no more strain as you feel usually after doing the surgery under the traditional surgical microscope. Also, while doing the surgery using the 3D visual system, I prefer to use the temporal approach rather than the sitting superiorly or the superior approach, as you can face the panel screen directly, no need to turn your face to look at the screen. There were no complications in all my cases, and also I don't find any difference in the post-op results regarding the clarity of the cornea, IOL centration, and the best corrected visual acuity. In these some pictures, I don't record any videos. You can see in the first picture, removing the cortex through the screen, and in the second one, doing the stromal hydration for the paracentesis, and the third one, the stromal hydration for the main phaco incision. The advantages and limitations for the 3D visual systems, especially for the Ingenuity, the potential advantages include similar surgical time, complication rate compared to the conventional microscope, and decreased power of endo-illuminator, which can lead to reduce the phototoxicity, and it's easy to use the in uncommon situations, including severe kyphosis. There are some limitations as difficult logistics, the bulky machine inside the OR room, the cost of this machine, and the assistant discomfort, and difficulty to use this machine, especially if the patient moves his head during the surgery, and also in case there is media opacity, there are poor review. And thank you for attention.
Thank you, Dr. Hassan. Excellent presentation. Definitely it's just something really interesting that is happening. And I would like some audience we can take some questions, or if not, we can just continue. And of course, we have on the co-moderators, Dr. Sandeep, or anybody would like to add at this point. Then, of course, I do see right there, Dr. Sandeep is there. Yeah. So
regarding the use of 3D system in anterior segment, I think the big problem here is that the phacoemulsification, it takes a very short time to finish. But for a corneal transplant surgery or a lamellar surgery, for example, deep lamellar surgery, if you can combine this with the OCT, this will be a big advantage because in those cases, probably 3D system really helps because you need to see the depth. So I think for a corneal surgeon or a DMAC surgeon, I think it's a great useful tool. But just for a phacoemulsification, I don't think it's going to be an investment you would like to do.
Thank you, Dr. Sandeep. Now it's time to introduce, if I can take the next 15 minutes just introducing Dr. Aik Ahmed. He is a great human being, an internationally accredited teacher. I would call him somebody who has done more than any words can define his area of anterior segment and glaucoma. So I would like to give this my opportunity to introduce him. Dr. Aik Ahmed would be taking the next talk on challenging cases. Please go ahead.
Assalamu alaikum, Hayat. Assalamu alaikum to everybody, brothers and sisters around the world, and especially in Dubai and UAE. It's a pleasure to be with you all. I very much enjoyed all the presenters that spoke today. I think the presentations were top class. Dr. Shakir Kiri, I really much enjoyed your talk on microspherophakia, and Dr. Safar and Dr. Khalid did a wonderful job on 3D, which I'm excited about, but I also share the same questions that exist, and I think we'll see more technology going forward. And of course, my good friend, Hayat Khan, who himself is a wonderful human being and a great heart. Thank you for having me as part of this, and thank you for inviting me to this great conference, which I know is a very big conference. I'm here in Toronto, and it's been a long time since I've been into the Gulf region. I look forward to visiting. So I chose my talk to talk about some challenging situations during cataract surgery. And I felt that it would be perhaps useful to focus a bit on the iris. There's many different ways to talk about challenging cases, and in 15 minutes, it's difficult to cover all of this. So I thought I would focus on an area that has been a passion for mine, that is often, coincident with complex anterior segment reconstructions, whether it's corneal or lenticular in nature. And these are my disclosures that I'd like to declare here. Of course, these patients, I believe, are often neglected in our ophthalmic world. With the photophobia that exists, the cosmetic appearance, which can be quite disfiguring to the patient, I think is sometimes ignored because the patients may still have reasonable vision. But the self-esteem and the impact on how society views the patient and how they view society is greatly impacted, whether we agree or not, by the appearance of the pupil and the appearance of the eye. And to our patients, this is often more disabling than the actual visual acuity itself, which may be surprising to us as ophthalmic surgeons. And merely reconstructing the pupil can be of significant quality of life improvement to our patients, where they feel they can live a more normal life. And so the opportunity to do this and to repair it, I think, is a great opportunity for us to try and help our patients. However, these are difficult and challenging cases, and they require not only the technique, but also the artistic nature of what we do to address the appearance of the pupil. And we try to look and see whether we can utilize existing tissue or whether a prosthesis may be required. We see whether the capsular bag may be used as a carrier for prosthesis, or whether we need to suture a prosthesis in, or we do a combination of approaches. Now, there are a variety of prostheses which are not always available, and there is an expense to this, but the Morture prostheses are the least of the expensive type of implants. And these are designed, these ones I'm showing here are designed to be placed in the capsular bag as modified rings to cover iris defects, whether they're diffuse or sectoral. There are also anterior lenses, as you see here in the bottom right, suture to the sclera, which have a central optic that can be used. Certainly the innovation of the human optics implant, which is a beautiful implant that can be placed in the capsular bag or sutured in the sulcus, really takes it to the next level. And the ability to customize these prostheses to the patient's eye color can be fantastic. This patient has congenital aniridia and cataract, and you can see I've done the left eye already, and we're doing the right eye next. And I told the patient you can pick any color iris you want from a magazine, and we can put it in your eye. That's what we did. And this is the prosthesis here, and you can see in this case it was a toric lens with this cataract and aniridia. And just to forward, we put the lens in the capsular bag, and we put the prosthesis into the capsular bag as well. We trephine it down. I typically do about a 9 to 10 millimeter implant into the capsular bag, typically a little bit larger if it's not in the capsular bag in the sulcus. And if it's in the sulcus, we always suture down. But it's quite really a nice cosmetic result, as you can see for this patient. However, I will say that I primarily like to suture as much as I can. I think the ability to do this in a more budget-friendly way and also can result in very good cosmetic results. There are a variety of ways to allow us to suture the iris, and I encourage us all to learn the different approaches that can be out there, including the standard mechanical, which is the classical approach. One thing to remember is that it's very helpful to have the right instrumentation, and here's a couple of tips. Using different hooks, Kugler and Sinskey hooks are important. And I do think having the right microinstrumentation are helpful. And nowadays with microinstrumentation in the vitreoretinal and anterior segment space, we have the availability of these tools in our toolbox, which are very handy. I use micro graspers and micro scissors a lot. I use micro tires to tie suture in the eye, and there are smooth tip platforms. These are specially designed, but really one can use a variety of different instrumentations that are available. And these are very handy to be able to do it. So one of the most common approaches, and that is easy to remember, hopefully, is McAhmed. My fellows named this one. Basically, we pass the needle. This is typically a 10-0 polypropylene suture. I should have mentioned that earlier, that the suture we use is 10-0 polypropylene for most cases. This is on a CIF4 needle. And what we do basically, we pass the needle through the iris tissue, coming out through the main incision. We then bring the free end out through the anterior chamber out to the main incision. This is simple to do. We then wrap around the long end of the suture around the micro tire and grab the short end and pull it through. And then we push the short end into the eye. This is sliding the nut into the eye, and now we have a cinch down. Some of you have heard about the four-throw pupiloplasty technique that Amar Agarwal had popularized, and that can be used with the same approach. And I like to throw one additional locking knot, however. And then there's intraocular tying techniques, which we designed many years ago, which can be used to suture, in this case, suturing an iris implant to the iris, the IOL to the iris as well. It can be done. So this patient here is an example. You can see the iris defect present in a patient with pseudophakic who had significant iris prolapse due to floppy iris syndrome. And although there's missing iris, you can see we're basically stretching the iris and we're seeing that the iris is quite elastic. The placement of incisions are very important. We strategically placed these incisions so we can take advantage of the long curved needle that can be placed here using the assistance of the microforceps to grab the iris. And this is very much like passing sutures, but in the eye, of course, it requires really good spatial awareness and maneuvering of our fingers and twirling of our fingers with passing the needle through the eye without grabbing the cornea and without putting traction on the iris, which could cause a larger buttonhole. We take the Kuglen hook and we basically pull the sutures out of the main incision, and then we can now tie the suture outside the eye. I have a tying forceps in one hand and a micro tie in the other hand. This is the Mick Ahmed, as I said. It's like the Mechanal, that's why they called it Mick in there, but we're basically using a micro forceps to wrap around the long end and push the short end into the eye. To me, this is one of the most straightforward techniques to learn, and it's basically helpful to control the passing of these sutures here with these micro instruments. And now you can see we basically have brought the iris together. We'll bring the suture out of the eye again. And I like to knot the eye. I'd like to put a knot in the suture. I just find it to be more secure and less concerning about it slipping and loosening later on postoperatively, especially if the tension is somewhat high. So we basically are going to pass multiple sutures here through the iris defect and close it. There's 3 sutures that are going to be placed in the defect here. And this is not one surgery to basically rush through the case. We want to really, carefully pass sutures, avoid making TI defects and buttonholing the iris, because that can cause transillumination defects and a problem. Now, the pupil is looking better, but we're not happy because we want to get that pupil to be nice and round. And to our patients, one of the most important aspects of a normal looking eye is a round center pupil. We take great effort to do this. And this means having a critical eye to imagine and visualize where the iris tissue is coming together. I'm going to remove this little strand of iris there. And now I'm going to show you the intraocular tying technique, which is a little bit more involved, using 2 micro tires in the eye. And this is really the importance to teach surgeons about using the fulcrum, using the incisions as a fulcrum, and really avoiding pushing and pulling the eye, and letting our fingers do the work by twirling in our fingertips. This is the true art of microsurgery in the eye. And we do this with cataract surgery in some ways, but it's important that we adhere to the principles of micro closed system surgery by doing these techniques. And a micro scissor is used. And so you can see at the end of the case, we have a reasonably centered pupil that's round. And you can see that postoperatively, the result of this patient that is now difficult to tell the difference when you see the patient at a distance. One of the things that I like to do is use iris cautery, iris endodiathermy for pupiloplasty. This allows us to modify the iris position. In this case, for example, we have correctopia and we have a decentered pupil. And what we'll do is we'll pass a suture to approximate the pupil there. Remember that this is an art in progress. What we see right now is not going to be the final outcome, as you'll see. We're basically bringing the iris tissue together to allow the pupil to reform. And then we're going to watch, I'm using my endodiathermy bipolar here to reshape and draw the iris here more superiorly. And this will again reposition the iris and the pupil more centrally. We'll continue to pass sutures in as the techniques I showed earlier tying the suture, close the defect. And again, take time to get that pupil more centered by making one additional pass here. But the pupil looks still a little bit irregular. You can see the straight edge there. So place the cautery. The farther away from the edge of the pupil, the greater effect you have, the less effect you have. So start more conservatively. And you can see we have a reasonably round pupil at the end of the case that looks fairly consistent. And we can do a lot of work. This is actually a pupil cerclage that was done as well. Finally, this is a patient who has a very large iridodalysis with a cataract. And we will take care of the cataract first. We're going to place some iris hooks to keep the iris away from the field. Vision blue, capsulorhexis. The IOL goes in the bag after routine cataract surgery, and then we can now address the pupil. In this case, you'll see that there's a large, almost 5 clock-hour iridodalysis, and we will try to smoothen out the iris. It's good to get to these cases within the 2-3 months of the trauma to avoid fibrosis and too much synechia. We don't have to go right away, but we'll do it within 2-3 months. And now we're going to make a groove just behind the blue zone of the limbal area. And in this case, we're using a straight STC6 needle. And this is the best needle we like to use for iridodalysis. And we're going to place mattress sutures. Now, there's a variety of approaches that have been used, including the sewing machine technique. I like to use interrupted sutures like this, mattress sutures. I'm docking the suture with a 27 gauge needle. And we have to approximate. Remember, the arc length or the circumference of the iris is going to be shorter than the arc length or the circumference on the sclera. So take wider space between the suture bites as you go out of the eye than in the eye. And this will allow the iris to spread over that circumference. And we basically want to grab a bite just from in the peripheral aspect of the iris. And so the idea is now to pass multiple sutures here. I'm not going to tie the suture. I'm going to put a slip knot, because we have to finalize the tension after we place the additional suture bite. So do a slip knot as you see here, and this allows us to titrate the tension nicely. You can see I'm approximating where to put the iris next, and I'm going to place another mattress suture there and there, and we have a second mattress placed, and we tie the suture there again, and a third mattress is placed here to allow us to close that defect. Now, the iris is looking better, isn't it? We're happy with it, but you know what? Don't stop. The pupil is still atonic and dilated. We repaired the dialysis, but we have not repaired the pupil. So we have to repair the pupil. So here's what I'm going to do is I'm going to take a CIF4 needle and we're going to repair the iris, the pupil. And we're going to use a running cerclage overlapping technique by bringing the iris to the needle. And this allows us to really nicely create a nice round pupil. We're going to do this in 4 passes, going across the quarter of the eye here, and then we'll go double arm to this way. It's helpful to use both hands, be ambidextrous, and you can see the bit of traction that's placed here, so we're going to have to adjust that. And we go all the way around, and then we're going to tie our suture again like the McAmmond approach, bring it into the eye, and lock the knot when we're happy with the size. You can see I'm putting some traction here so I can adjust the knot here at the end. It's okay not to do it very tight. As long as it's close to the angle, you can hang it back a little bit. And we finalize the suture here, and we're done. And we have a nice round pupil. So those are many of the techniques that I want to share with you. And I know there's lots to discuss. So much is available online, and I look forward always to communicating with some of you on Instagram or Facebook or YouTube. That's the way we've been able to keep in touch these days during the pandemic, and keeping us together and keep on learning. So thank you for the invitation again, and I appreciate the honor of being here.
Thank you, Ike. I think we have a lot of time to ask many questions for all the speakers. Anyone from the moderator, Dr. Sandeep or Dr. Prasan, Dr. Hayat? I think I will ask first Dr. Ike. Did you find any difficulty to dilate the pupil if we need to dilate this pupil, if you are doing cornea? This is all the suture all around the pupil. If the patient needs to be dilated for any treatment, laser treatment, or even to examine the fundus?
Yes, I mean, of course, depending on the size we make it, that's going to be the size if it's a circumferential cerclage. If it's a small closure, locally, then you can dilate the rest of the pupil. So we typically like to leave the pupil about 3.5 millimeters. This is the best size for photophobia. my retina colleagues aren't always happy, but really with the wide angle viewing systems and with indentation ophthalmoscopy, this is generally still achievable. Now, of course, if it's a very bad diabetic or something, then I think it's better to leave the pupil larger. And if it's worst case scenario, we can cut the suture and the pupil will dilate if necessary. So we haven't really had a major issue, but I know I hear this question and I would be cautious, of course, in a high risk patient, but if necessary, you can always cut the suture, and 3.5 millimeters, you should be able to do a good peripheral examination, although I know it's somewhat more challenging.
Dr. Aiki, first of all, thank you very much. It's wonderful to hear from you about the repair of iris. Just one question. Have you approached patients with essential iris atrophy? Where have you, what sort of approach you take there? Because the iris is very friable in these patients.
Yeah, if the iris is very friable, I don't think they're amenable to suturing, and especially if it's a proliferative condition like essential iris atrophy or eye syndrome or other conditions like this, I prefer not to touch the iris. In those cases, I typically go to iris prosthesis, preferably in the capsule or bag if we can, or sutured if necessary. But those are trickier ones. I don't like to suture those. And it's important to remember the difference between the pathological iris conditions where we're using prosthesis, where we remove iris, versus the cosmetic iris implants, right? We don't like cosmetic iris implants. These things are sitting on top of the iris. They cause lots of problems. But these specifically medically indicated iris prostheses are different. We're putting them in conditions not in the anterior chamber. We're putting them in the posterior chamber and in the capsular bag often.
The problem with IC syndrome is that many of them have poor endothelial count as well. And in these cases, putting a prosthesis, of course, do you think they have any risk of progressing with their endothelial problem, or in the bag they're fine?
I wouldn't do it alone. I mean, if you're doing cataract surgery, then I think it's useful to combine it with a prosthesis in the bag. I don't believe the endothelial cell loss will be any greater than with the phaco. But to do it just for the purposes of repairing the iris, no, I wouldn't do it for that purpose. I think that I agree with you. I think there's too many risks. I would only do it if I was combining with cataract surgery in that example.
Thank you, Dr. Aiki. That was great.
Yes, I have a comment regarding the correctopia patients. I mean, I do see a lot of pediatric patients, young patients coming with just nothing but just correctopia, bilateral sometimes. And the parents are really worried. I think this opens up a whole, especially the cauterization, with which actually you can beautify. It's a kind of a stigma a lot of patients do have. If you see on their personality, you can talk about it, then you'll know. It would actually improve a lot of not only cosmetic, but the whole personality. And thank you, Dr. Aik, for this kind of presentation, which makes us think as how we can help these patients, which we were earlier just telling them, well, we have nothing else to offer. Regarding the microspherophakia, I have Dr. Aik, I have Dr. Nihal. I mean, they both have huge numbers. I do have sometimes patients where one eye has corneal opacities because sometimes it's completely subluxated, while the other eye is a good eye, which has no cataract and is a better seeing eye. And one day they come with an anterior subluxation. I have tried doing pilocarpine and putting it back. What is your take? Would we take out that lens or would you just leave it for then?
The question for me, Hayat?
Yes, one by one, you and Dr. Aik.
Well, I think once you have a microspherophakia, you know that I did maybe hundreds of cases of microspherophakia, and I saw many cases nearly every month. I think once you diagnose it, I think it has to be removed. There is no role of closing the pupil over it. It will not prevent the complications, and it will definitely go into either posterior dislocation or anterior dislocation or any type of glaucoma. And I have many patients blind because of delayed diagnosis and delayed treatment. So the best thing is to remove it. Number one, you're gonna treat the high myopia, which is also amblyogenic, and I usually see -15 and -20 myopia, and it is a lenticular myopia actually. And we see very high astigmatism which is also embryogenic. And apart from this, you see there is a high rate of anterior dislocation, and sometimes when the patient refuses to go for surgery, it dislocates posteriorly and then anteriorly, and then end with giant retinal tears and retinal detachment, which is very difficult to repair later on. So I think there is no role of any peripheral iridectomy or glaucoma surgery or pupillary reconstruction, and the only line of treatment is to remove the lens.
Dr. Aik, would you like to add?
Yeah, I completely agree. I think it's a wonderful presentation from Dr. Shekankari. I really enjoyed it, and I completely agree. This is a surgical issue, and I do see, unfortunately, misdiagnosis, and I see PIs done with further IOP problems. I see TRABs done with complications there, and I think these should be handled by an expert surgeon, as we saw from Dr. Shekankari's talk. You know, sometimes they're subtle. I mean, they're extreme examples. Sometimes they're subtle, and sometimes they present later on as well in patients that are older. And so always have your, you know, your antenna up when you see somebody with high myopia and someone who has a normal axial length and their keratometry is otherwise routine. You know, I deal with a little bit older population, you know, patients who are a little bit older, and you know, I tend to use a lot of capsular tension rings and segments and suturing them and everything, all the gymnastics, which I don't know if I can tell you that the outcomes are any better or not, but that's the way I have typically dealt with it, is to retain the capsular bag and use capsular tension segments and rings and suture them to the sclera and put IOLs in bags. But this is obviously a good controversial discussion, especially when it comes to very young patients, where I agree that the IOL is not necessarily the right answer. But with their older patients, you know, in my example, you know, we have 3, 4, 5, 6-year-old and older patients. I quite often will do that. I'll do a posterior capsulorhexis and a buttonhole with the IOL. And it's a lot of work, but I think it might be another option.
Well, actually, concerning intraocular lenses, maybe this is feasible for cases of ectopia lentis, but microspherophakia, the lens, the diameter of the capsular bag is small, and even if you suture it to if you put capsular tension ring or suture it to the sclera, the capsular bag is small. It will not accommodate the usual intraocular lens. So in cases if you're going to leave the child aphakic because the age doesn't permit you to implant intraocular lens, there is no role of leaving capsular supports. As you saw, all cases go to a shrinkage of the capsular bag and opacification of the visual axis. And we had to remove this bag at a later date. But if we tend to implant, I prefer the iris glow lens because the capsular bag originally is small. There is no, maybe it is feasible and possible to implant intraocular lens and use CTRs if it is not micro, it is not microphakia. It's a sort of a subluxated lens. I think it's going to be a wise decision to go for intraocular lens.
Yeah, it's a good debate. I'll tell you, I have many eyes that are 8mm diameters and even 6mm diameters, and a CTR will expand the bag. And a nice foldable lens will fit with the haptics compressed and the bag spread. I do lots of LEC cleaning with capsular polishing. We have a large series, but I agree, if this bag is really small, if it's 4 or 5mm or smaller, it's a problem. So there's probably a limit to that. But I think you can actually, believe it or not, for a bag that's maybe 7, 8, 9mm in size, which isn't extreme, I agree, if it's extreme, then you can. But I agree, if you can't put a CTR and suture it in, then there's no role for an IOL in the bag.
That's really interesting and very nice opinions from all part of the world. Thank you so much, Dr. Aik Ahmed. Thank you, Dr. Nihal. Thank you, Dr. Hassan. Dr. Prasanna Rao, would you like to add something?
So I'm in awe with all the videos and amazing photographs from Dr. Nihal and Dr. Aik. As usual, these videos are amazing. I think he's more a ocular plastic surgeon, the intraocular plastic surgeon, I would say. Amazing results with his iris corrections. As a retinal surgeon, we do have cases where we have trauma patients who have iris problems. Our main aim is just to fix the retina, and I think Dr. Aik is doing a wonderful job of fixing the irises. Thank you for your excellent videos.
Thank you for everyone. Any other question from anyone?
So Dr. Aik, since you have used, just one quick question, since you use both Ingenuity and the Artivo, do you find any difference between them, or both seem similar?
Well, we're doing a study on this. I think they're both good systems. I mean, obviously, the Artivo is built from the ground up for 3D with 2 4K cameras and a little bit more resolution. The latency is less, but it's very hard to perceive the differences. You know, so I think they're both good systems. But I will say the Artivo is basically built, so it's very easy to go back and forth, and it's designed with the optics in mind for this. But you know, we're doing a study, to be honest with you. So we have both systems, and we'll see what they show. It's interesting, though. It's hard to show differences, as you saw from the presentations today. And so, you know, these are where we talk about surgeon preference, posture, and image manipulation, and surgical guidance, which I think is the future.
Any experience with the bionic eye?
Yeah, Bionics also has as you know, a headset display, and I've used it in a non-clinical setting. So this is also very exciting, where you have a VR setup and you have gesture control, and you can look at your OCT, look at everything you want, and you can move it around, and you have everything in front of you. So that's fascinating. I think it's potential something that may also come.
Yeah, thank you very much.
Everybody and their toys.
Thank you for everyone. Thank you. Thank you, Dr. Passan.
Thank
I
you
think
very much.
yeah, we come to the end of this session and the end of this day. I thank everyone. I especially thank Dr. Muhammad. And tomorrow, inshallah, we will start in the afternoon our virtual meeting. Thank you for everyone.
Thank you.
Take care. Assalamu alaikum.
Thank you so much.
Thank you,
Stay
everyone.
safe.
Thanks a lot.
Thank you, everyone. Bye-bye.
Thank you.